expertise. We also have Dr. Charles Okot, the EPI pillar lead, and Dr. Felix Sunny, who also is in the EPI pillar. We have Fred Ratibi. He leads the lab pillar. We have Dr. Olaolu Aderiola. He supports us on the Emergency Operations Center for Cholera. We have Dr. Keita Mori, the Regional Advisor for Infectious Hazard Preparedness. And then we have Dr. Fred Kapaya, an epidemiologist who primarily focuses on cholera preparedness and readiness for the region. So just to acquaint us with the features we have for this presentation, we have the Q&A icon at the bottom of your screen. It's a feature which we'll be using for questions. So please kindly put all your questions in the Q&A regarding any of the presentations. And then we also have the chat feature also at the bottom of your screen that can be used for any questions regarding the IT or logistics. There's interpretation available for these sessions, and we'll be interpreting in English, French, and Portuguese. And you can access any of these by clicking the interpretation icon at the bottom of your screen. You select which is your preferred language. And if you only want to hear the interpreted language, please also click the mute original audio so you listen to only one. An additional feature we have is the live transcription. If you want the transcription, you can click on show captions. And if you do not want to see the transcription, you click on hide captions. Finally, just to let you know that the session is being recorded and your attendance is taken as a consent for the recording. And we'll be recording in the 3 languages, and these recordings and all other session materials will be emailed to participants in the days following the webinar. Your feedback is important to us, and so we'll be sharing a survey at the end of the session. Kindly respond to this survey and submit. And once again, thank you for joining us in this session. So I'll be inviting the incident manager for the AFRO region, Dr. Ramadan, who will be giving us his opening remarks. Dr. Patrick, you're welcome.
Thank you very much, Professor Debola, for the introduction, and welcome, colleagues. Good morning, good afternoon, and good evening, wherever you are. Thank you for joining us in this session. It's really an honor to join you and discuss a very important public health condition, which is cholera, which affects a number of people within our region. It's unfortunate that in this day and age, it's a disease that we still have to grapple with, but we are confronted with the challenge, and I'm glad that most of you, I think, on this call have been contributing effectively in your countries towards the investigation, confirmation, management of cases, and implementation of interventions to control cholera. Cholera, as we know, is a waterborne disease, and it primarily affects communities that are already grappling with the inadequate sanitation, limited access to clean water, and overcrowded living conditions. So far for us within our region, the statistics are still sobering. We see that cholera claims thousands of lives every year. I think from January 2020 to now, we have lost over 4,000 people within the region. We have recorded over 200,000 cases, as Adebola will present to you, within the region. So it's an important public health event that we have to continue to address. And one of the things that we have to be cognizant of, what are the factors contributing to the outbreaks within our region? So we have seen climate change, which is a very, very critical player in terms of the El Nino, the La Nina impacts. We have had cyclones that have had devastating impacts in countries. We are seeing shifting of humanitarian conflicts resulting in displacements and conditions in crowded living settings where it's very, very easy for a waterborne or sanitation-related outbreak to occur. We have had droughts in the Greater Horn of Africa, resulting into significant food insecurity, lack of access to clean water. We have also seen increased fragility and vulnerability of our populations due to the impact, economic impact and social impact of COVID-19. So all these factors are really contributing to an increase in cholera within our region. My message today is threefold. The first one is prevention. Preventing cholera begins by addressing the root causes of its transmission. And that is improving water and sanitation infrastructure, increasing access to safe drinking water and proper sanitation facilities, ensuring that we do hygiene promotion in the communities. And these all have significant impact by teaching individuals how to properly handle food, how to wash their hands, how to manage their waste in the communities. These are very, very important. And I would like to emphasize that much as we will be dealing with the response, the issue of prevention remains a very, very important aspect that we have to deal with. The second one is early detection. A number of the outbreaks in our region have been detected late, have been confirmed late. We really need to continue to work to increase the index of suspicion of healthcare workers, to increase the capacity of healthcare workers to be able to detect the signs and symptoms of cholera, which are very, very easy to detect, but also to be able to report promptly and ensure that rapid response is initiated. The detection also involves the issue of lab. The countries need to have capacity to confirm a cholera, and my brother Dratibi will be talking about this. The third issue is the effective management. Effective management deals with all the 6 cardinal pillars of cholera response. And at the center of it is the community engagement and health education and risk communication, which we have to do effectively for community to appreciate the interventions that we are implementing. But the second issue is the water, sanitation, and hygiene, which is not very strong in most of the responses that we are seeing. The collaboration between the health and the health ministry, the ministries of sanitation, of hygiene, of environment is not very critical, is not very strong as it should be in these responses. And that's what we have seen. The third issue, as I mentioned, is surveillance and reporting. It has been very inadequate in most of our countries, and we need to strengthen that. The case management, we have seen that the case fatality rate within our region remains unacceptably high. The WHO threshold is that we should maintain cholera case fatality ratio below 1%. But we have been hovering above 2%, and it is still unacceptable. In some countries, it has gone as high as 3% or 4%. And we need to ensure that case management is really strengthened, and decentralization of care, ensuring that people have early access to ORS at the community level so that we prevent them from deteriorating to severe dehydration. The leadership and coordination, particularly multi-sectoral coordination with the different actors, remains very, very critical. And then the issue of reactive vaccination, because now we do not have sufficient doses of the oral cholera vaccine to do preventive, we are doing reactive. But countries have been presenting their requests very, very late, in the sense that it cannot be able to alter the course of the outbreak. And that is something that we have to do very, very effectively. So I would like to really appreciate all of you for making time to participate in this webinar. I encourage that we continue to support our communities and in terms of prevention, but also we detect the outbreaks early, we respond quite early, and we ensure that we are able to prevent the outbreaks from escalating to the extent that it becomes very, very challenging for us to contain it. Cholera is easy to manage, the deaths can be prevented, and even the outbreaks can be prevented if we address the root causes, and if we invest in that is access to safe and clean water, and if we ensure that we are able to mount effective response. And the purpose of this webinar is to bring us all up to speed in terms of what do we need to do in detection, confirmation, and effective response to cholera. And I wish you all a very fruitful deliberation, and we will be available to address any concerns and questions that we have around the topics that will be presented today. Thank you very much for making time to participate with us in this webinar. Over to you.
Yeah, thank you very much, Dr. Patrick. And so, and thanks for those opening remarks and reminding us about cholera within the region. So I'll be going on just to present an overview of cholera response strategies, just to kind of set the background for the webinar. And then we go into the specific pillar responses. So this will be the overview of cholera response strategies, and this will be my outline for the presentation. Just to give us some background regarding the context of the outbreak currently within the region, Dr. Patrick had mentioned the various contexts within which this outbreak is happening. We have 15 countries in the WHO African region that is currently affected. And we have the conflicts of natural disasters, the context of natural disasters, things such as floods, droughts, conflicts. And we also remember that many countries have limited and strained resources. And there are also some challenges with countermeasures, as Dr. Patrick has mentioned. And then we've got poor sanitation, which is really the crux of the matter, and unreliable water supplies. And of course, there's also the aspect of increased movements. The epic curve shows what the pattern has been since the beginning of January 2022 and up to where we are. We are gradually seeing a decline, but we're not yet where we should be. And the map shows you the various countries that have been affected and their distribution within the region. But coming to outbreak response, when we're responding to cholera outbreak, there are two areas that we need to focus on. We need to focus on limiting mortality. There's no reason why people should be dying from cholera because it's preventable and it's treatable. Then we also need to focus on reducing the spread of the disease. Now, looking at these two factors, whatever we're doing needs to be comprehensive and needs to be multi-sectoral. So it's not just for the health sector. And all these efforts must be well coordinated. But to get rid of cholera in the long term, we're going to need improvements in water supply. We're going to need improvements in sanitation and hygiene measures. We're going to look at our food safety programs within country. And then the community needs to be aware of preventive measures to take. And these really are the best ways to prevent cholera and other diarrheal disease. So a background on the disease, it's a disease that is caused by infection of the intestine. The microorganism that causes it is called Vibrio cholerae. And there are two types that cause cholera, type 01 and type 0139. 20% of people who get infected develop an acute watery diarrhea. That means that you have 80% of people who may not have an acute watery diarrhea, but they can still be transmitting the infection in the community. Of these 20 that get symptoms, another 20 of them will develop a severe watery diarrhea and they may have vomiting. If they're not treated promptly, they die within hours, and the case fatality can be as high as 50%. However, if they are treated promptly and appropriately, the case fatality rate should remain less than 1%. And we reduce the spread by detecting early and confirming that it's cholera, and also by having a well-coordinated response. So for elimination, we need a multi-sectorial cholera preparedness plan that will be well implemented in the countries. Just to also remind us of how it's transmitted, we have these, what we call the 6 Fs, either from feces to the fingers or carried by flies or in the fields, getting into the food and then getting into the new host, and also through infected fluids. Children and adults are equally affected, and the incubation period is from 2 hours to 5 days. Like I mentioned earlier, if people with severe form of disease are not treated, we could lose half of them. So looking at the response, so how do we mount up an effective response to an outbreak within our countries? We have different pillars for response, and then we have the different components. So for the components, when we talk about emergency coordination, we have the leadership, the coordination, the planning, and the monitoring pillar. And this includes the prevention of sexual exploitation and abuse. The other one we're looking at is surveillance. And for surveillance, we're looking at the epi-surveillance and health information pillar, and we're also looking at the laboratory diagnostics and testing pillar. Then it's essential to provide safe and reliable care. And we're looking at case management pillar. We're also looking at the infection prevention and control pillars. So we use these pillars of response to ensure that we're delivering an effective response, looking at these core components. Then for community protection, in protecting the community, the risk communication and community engagement pillar is critical. The water sanitation and hygiene pillar is critical, and the vaccination pillar. And then, of course, if we're talking about a response, we need access to countermeasures. Countermeasures here refer to the drugs, the vaccines, the testing implements, the IPC supplies, and then we need the operation support and logistics pillar. So we use these pillars to be able to mount effective responses within the country. Now, these are two helpful resources that are available to us. I mean, they're freely available online. To the left, we have the outbreak response field manual, which provides a lot of information regarding how to effectively respond to an outbreak, and it's intended for public health professionals and program managers. And then to the right, we have the Cholera app that is freely downloadable onto your phone. And this is designed for use by frontline cholera health workers, those who are responding at the front line, and it serves as an easy reference. So please, let's ensure we have these two to help us to know how to mount an outbreak. Now, there's always a lot of talk about rapid response teams and what they do and how they do their work. But sometimes we find out that RRTs go out and they're not sure what to do. What is expected is that RRTs should be deployed within 24 hours of the outbreak, and they are meant to go to investigate, to confirm, to assess the risk of spread, and also to conduct an initial assessment and implement initial control measures. The RRTs are meant to be multidisciplinary, and I have a list there of the kind of people that need to be a member of the RRT. So you have the clinician with experience in management of patients, of cholera patients, you have the epidemiologist, you have the IPC WASH experts, the community engagement and risk communicator, and you have the laboratory personnel. And RRTs need to know the elements to investigate. So it's not enough just to send people to the field, but they need to know what to do. And these teams should, in addition, not just go, but carry enough supplies and also have the guidelines and the protocols to be used. So in responding to cholera, we have different pillars, and here we have the summary of what each pillar is meant to do. So we have the coordination pillar. This is really meant, this is the center point of the response, coordinating, getting the information, taking decisions, planning, estimating the needs, coordinating the actions, and in addition, ensuring that the minimal requirements for prevention of sexual exploitation and abuse are in place during all response. We have the epi-surveillance pillar that compiles data daily to describe the outbreak, and they also lead in field investigations, identifying the possible source of contamination, the risk factors, and transmission pathway. Then we have the case management response pillar. This ensures the setting up of the oral rehydration points and the cholera treatment units or centers, and also training health workers and working closely with the other members of the team. The IPC and WASH pillar, they ensure safety and minimize risk of infection transmission within the centers, and also ensure access to safe water within the center and within the community, with improvements in sanitation and hygiene measures. The risk communication and community engagement pillar is one of the most critical pillars in response to cholera, because this engages the community, making them understand the preventive measures and also promoting their early treatment by early visits to the health center. And vaccination can be considered depending on country context and depending on the level of the outbreak. But if this is going to be done, it should be done early enough so as to be able to contain the outbreak and reduce spread. And of course, the operation supplies and logistics, they ensure availability and access to needed supplies. So what are the first steps when you're talking about cholera response? The need to activate a cholera coordination mechanism is critical. It's important for countries to develop response plans so as to mitigate the risk. It's also important that control measures be mitigated. And like I mentioned, the two areas are to reduce mortality and to reduce the spread of the disease. And then adequate estimation and procurement of supplies is critical. So the last words on this overview is that the control of cholera outbreaks and prevention is critical to countries, and countries need to build capacity for early detection and immediate and effective response. The coordination and collaboration is essential, and this goes across sectors, across partners, across governments, to train health workers to provide the needed supplies to improve access to clean water and sanitation, to understand the epidemiology of the outbreak, to provide public health guidance, and to work with communities. Every death from cholera is preventable, and I want us to always remember that. But it's preventable only if we're able to detect early, if we're able to implement an effective response. And the longer-term solution lies with our governments in terms of economic development and in terms of universal access to safe drinking water and adequate sanitation. So thank you, and I'm going to stop here.
Thank you so much, Professor Bola, for giving us that overview. I really want to ride on your one of your last words, that every cholera death is preventable. Thank you so much for giving us the overview of the cholera response strategies. And this is setting the tone for the series of webinars we'll be having for the next 3 sessions starting today. So keep it. We expect that you continue to join this. I will now introduce the next speaker who will be talking on surveillance, with particular emphasis on declaring and the start of an outbreak and end of an outbreak. So we'll be inviting Dr. Felix Sani, who will be taking us on this. The floor is yours, Dr. Sani.
Thank you, Dr. Lalu. Thank you, Prof, for the beautiful presentation. So in this section, we'll be talking about declaration of a start and end of a cholera outbreak. This one mainly concerned the surveillance and outbreak investigation unit. So we have the outline here. We'll be discussing case definitions as well as cholera outbreaks. I will not go into details about this again because both the IM and Prof have emphasized on some of these things, that one of the reasons why we need to intensify surveillance is because some individuals will not show symptoms, or why some may develop severe dehydration, which can lead to death within hours if not treated. Also, limited access to health facilities and inadequate treatment of cases associated with high mortality. So the surveillance units has to be improved and enhanced. This we aim to define and some cases definitions, as I said, and as well as outbreaks. Based on the GTFCC Global Task Force on Cholera Control recommended case definitions, we talk about the first one is acute water diarrhea, as well as severe dehydration. When we're talking about acute water diarrhea, we have 3 components there: the acute, the watery, and as well as the diarrhea. Acute is defined as lasting less than 7 days, while watery is defined as a bloody liquid stool that may contain mucus, while diarrhea is defined as 3 or more loose stools within 24 hours. Talking about severe dehydration, these conditions are available, and they call them danger signs. The first of them is lethargy, loss of consciousness, absent or weak pulse, as well as respiratory distress. Or two of any of the following: sunken eyes, unable to drink, or drinking poorly, as well as skin pinch going back very slowly, especially when it is more than 2 seconds. Let's look at some definitions or look at suspected cases. Defining suspected cases, we look at in a situation or surveillance unit where there is no confirmed cholera outbreak. Suspected case is defined as any person, whether 2 years or older, that presented with acute water diarrhea or severe dehydration, or anybody 2 years or older dying from acute water diarrhea with no other specific cause attributed to the death. In cases where there is where we have a confirmed cholera outbreak, a suspected case is defined as any person that's dying with acute water diarrhea. In unit where there is a confirmed cholera outbreak, we talk about any person infected with Vibrio cholerae, as Prof said earlier, 01 or 0139, and this must be identified with lab results. Now let's talk about confirmed cholera case. We also talk about in surveillance units where there is no confirmed cholera outbreak. As I said earlier, you see the same any person infected with Vibrio cholerae, whether 01 or 0139, and this should be confirmed in the laboratory. We talk about imported cholera cases. An imported cholera case is defined as a suspected or confirmed cholera case infected outside of the surveillance unit where the case was detected. For example, if somebody travels from a country to another country and the person is infected from the first country, then whereas the case is detected in another country. So we call it an imported cholera, either suspected or confirmed case. Also, that must be supported by epidemiological, microbiological evidence, or both. Now let's look at locally acquired cholera cases. When we talk about suspected or confirmed case infected in the surveillance unit where the case was detected, that is when if the person is infected in the same district or the same country where the case is detected, we call it locally acquired cholera case. And this is divided into two as well. We have an imported related cholera case, which is locally acquired, and we have indigenous cholera case. It is imported related cholera case if the case is associated with another case that is imported. So for example, if somebody travels, as I said earlier, if somebody imports cholera into a country and another person get infected through the imported case, so it is still locally acquired, but is import-related case. But when the case is not associated with any external source or any imported case, it is called indigenous cholera case. Now let's look at some outbreak situations. We define the suspected cholera outbreak. We also define the probable cholera outbreak as well as confirmed cholera outbreak. For suspected cholera outbreak, as I said earlier, we should have 2 or more suspected cholera cases reported in the same surveillance unit within 1 week of each other. For example, if one suspected case is detected today, and within 7 days, within 1 week, another case is detected within the same surveillance unit, we call it a suspected outbreak. Or if we have somebody or a 2 years or older dying of acute water diarrhea without any other specific cause related to that cause, death, it is also called a suspected cholera outbreak. Or in another situation where there is one confirmed cholera case, pending the clarification of whether it is locally acquired or imported. So we call it the situation, whether in a district, in a country, we call it a suspected cholera outbreak situation. For probable cholera outbreak, the following conditions are necessary. I think the lab unit will talk more about that because it's more of or less lab related. Well, of 7 tested or suspected cases, at least 7 of them must be, 3 of them must be RDT positive. And when 8 to 10 suspected cases are tested, 4 must be RDT positive. And among 11 to 14, 5 RDT positive. For 15 to 17, 6 RDT positive. In these situations listed here, we call that situation a probable cholera outbreak situation. For confirmed cholera outbreak, we must have at least 1 confirmed cholera case locally acquired. At least that must be laboratory confirmed. That is when we say this, the situation, we have confirmed cholera outbreak. Then we define start date of cholera outbreak as the date of onset of symptoms of the first locally acquired suspected cholera case detected in this surveillance unit. Talking about surveillance unit, whether it's a district or wherever, the onset of the first locally acquired suspected case is the date or is the start date of a cholera outbreak. Then let us look at the criteria for ending a cholera outbreak. Number 1 there must be a well-performing surveillance system. And there must be an adequate laboratory capacity for testing cholera. We'll still talk a bit more about that when we get to the next slide. Also, in the case where the capacity, the laboratory capacity is still not adequate, and the way the surveillance system is not well established or performing, in such case, we can consider longer time before we declare the outbreak over. Now, these key performance indicators must be met before outbreak can be declared over. At least 90% of all signals detected within 24 to 48 hours must be investigated. At least 90% of all cases detected must be investigated within 24 to 48 hours. And that's the target should be weekly reporting. Also, there must be an adequate means for preparing and sharing a situation report. That one must be 100% and must either be daily or weekly, but the major target is weekly. So before any country or district can declare outbreak, cholera outbreak over, these situations, these key performance indicators must be in place. So looking at other criteria for ending cholera outbreak, we are looking at suspected and probable cases. At least for 4 consecutive weeks, all suspected cases, if any, must be, or if any, had a negative laboratory test result by culture or PR or PCR. That is, for 4 weeks, all suspected cases must be negative for PCR as well as for culture. Additionally, the status of a probable cholera outbreak can be downgraded to a suspected cholera outbreak if all suspected cases with a positive RDT result that triggered the probable outbreak had a negative laboratory test, either by culture or by PRC. That is, all cases that are RDT positive must be negative to culture and PCR. Now let's look at surveillance activities. All these activities must be in place before outbreak can be declared over. Number 1, we're talking about active outbreak. The country must have adapted and have the ability to print and distribute surveillance tools. That is talking about case definition, line lists, template, and case investigation form. That must be readily available and be widely distributed. Also, there must be training for all the surveillance staff at all levels. Also, there must be a provision to support to data collection, management, and analysis, including sharing analysis code. Another thing that is very important is that activities must be monitored particularly the activities of the surveillance team. Also, there must be support, development of situation and the information product. There must be support to get information products such as the situation reports, the analysis of reports, and as well as, if possible, the weekly bulletin or monthly bulletin. Also, there must be a good collaboration between the surveillance unit as well as and the RCC unit. For acute crisis, the same thing applies to acute crisis. Also, the surveillance activities must be duly monitored, and working closely with RCC is also important. Also, data collection and analysis, including sharing of code, must be in place in the surveillance unit. Also, the surveillance unit must support development of situation report and other information product, as I mentioned earlier. Now, let's look at how we report. These things must be in place for reporting unit, surveillance unit with absence of confirmed cholera cases. Detection of cholera suspected cases should be reported within 24 hours to local health authorities. So if there are no modalities to effect this, the outbreak cannot be declared over. Whether the outbreak is over or is not over, all suspected cases must be reported to local authorities within 24 hours. Also, standard tools should be used. Other colleagues have shared, Prof have shared some links to the GTFCC tools. There are two designed for line listing, data collection, and the reporting. Also, when there are zero reporting, this must also be reported that the district or the country is not reporting cases, especially when we have a confirmed outbreak. That doesn't mean that the local authorities or the high level should not be notified. Also, reporting to local health authorities using standard data collection, as I said earlier, that must be done weekly, and that must include zero reporting. And surveillance units is encouraged to have more frequent reporting, especially on when we have confirmed outbreaks. That has to be daily, if possible, where there are facilities. So we should note that in case where the timely reporting, it cannot be sustained, it's also allowed. That is rare cases, so for aggregate reporting. Thank you. This is the presentation from EPI unit. Thank you. Over, and if you have questions.
Yeah, thank you very much, Dr. Felix. Thanks for that beautiful presentation. So looking at the Q&A, and I think there have been a few questions. Some of them have actually been answered. By response, but there's a new one now. And maybe I'll just read that out. It says, are the response strategies the same or different for each of the type of cholera outbreaks? Talking about whether it's suspected, it's probable, or it's confirmed. I'm hoping that this question has also been answered in a way by Felix's presentation, because he clearly said what is suspected, what is probable, and what is confirmed. So if it's suspected, of course, you know you are preparing, you're in preparation phase. If it's probable, it could have happened. You know, when you say, is it the same? In a way, it's the same, but the focus is different. If you look at the global strategic cholera response and preparedness plans, it talks about the various phases, whether it's an acute phase, whether it's an active phase, or whether it's in preparation or in readiness. Once you are suspecting, then you should be ready to respond. And so your focus will be on your response strategies. If it's confirmed, you are definitely active. So your focus will be on reducing transmission, on ensuring people do not die. If it's suspected and it's not confirmed, you're not talking of death yet, but then you're going to put things in place. Such, for example, some of the things you'll be looking at is building the capacity of your people to respond, ensuring that you have the necessary supplies to respond in place. The next question says, could a negative RDT report to authority and could a negative RDT report to authority and taken to the laboratory? It's an incomplete question, but I'll say that hold on, because the next presentation is likely going to address that. And then we have another question that says, how important is cholera vaccination during an outbreak? Please continue with us in this series. We have a particular session for vaccination. That will be the third session. And before the end of the year, there's going to be a whole 2-hour session on oral cholera vaccinations, whether it's preventive or reactive, and you're going to get that. So I think it's better you listen to the comprehensive presentations than us trying to answer this. But we have a few focal persons on board. Rina, I think you can type an answer to the vaccination, and maybe later Fred will type an answer to the negative RDT report. For the others on the 6 Fs, or what is also known as the F diagram, there are some answers to that in the chat and a link to that. So thank you, and please keep the questions coming. We'll keep addressing them even as they come up, either in person or by typing the answers. So at this time, I'm going to invite our next presenter, Fred Ratibi. He's the pillar lead.
Sorry, Professor, we
Yes.
have 2 hands raised.
Oh, okay. Okay, so who is the first now?
Ibrima.
Yeah, no, I'm trying to look for the hand. Apologies, let me go to the right list.
Yeah. Ibrima, please unmute yourself and talk.
Okay.
Sorry.
Ibrima, you are muted. Could you please unmute yourself and talk?
Hello?
Yes, we can hear you.
Yeah, no, it's okay. It's all right. It's fine. It's already
Okay.
answered. Sorry. Thank you.
So the next one is Christopher. Christopher, please
Yes.
unmute yourself and talk.
Good morning, everyone, and good morning, Dr. Sani, for the presentation. Just a request for some clarity on your opening remark on the fact that most cholera cases are either mild or asymptomatic. So in cases where most cholera cases are asymptomatic, what will be the basis for surveillance, or what mechanisms will be used to improve early detection and surveillance? Thank you.
Prof, you're muted.
You are muted, Prof.
Sorry. Mohammed, I can't see the hand. Who is the next person?
I think it's Adesina.
Christopher has asked his question and we haven't
Yeah,
heard your
Christopher
answer.
has asked this question, and Ibrahim says the question has been answered. So over to you, Felix.
Okay, so
Thank you, Tamal. Thank you, Prof. As Prof has said initially, that sorry. Now, let me go back to why most infected individuals have mild symptoms. Some may develop severe dehydration, which can lead to death. That is why it is important for us as a surveillance unit to intensify surveillance. You know, as Prof said earlier, that some people may not be symptomatic, but they are quietly transmitting the disease or infecting others. So what we need to do in this case is that we intensify our surveillance, number one, and the once cases or suspected cases are identified, we try as much as possible to do contact tracing. That will help us to put all, whether they show signs or there are no symptoms, we'll be able to put them in surveillance radar. We'll be able to monitor, and if eventually they've developed symptoms, we go ahead to treat them. I don't know if other colleagues have information, further answer to the question. Thank you.
Okay, yeah, thanks, Felix. Maybe I can add a few more points. So 80% of people infected with cholera do not present with symptoms. But in situations where you have the practice of open defecation, for example, even though they may have mild symptoms or they are asymptomatic, if such a person who is infected with cholera practices open defecation, and through the 6 Fs, like we mentioned, the organism gets into food or into fluids that more susceptible people take, then you could get other people coming down with cholera. So even though people are asymptomatic and they are mild, it does not mean they cannot transmit the infection. And if you remember at the beginning, I said one of the things you want to do is to be able to detect. So ongoing surveillance is important. And that is why ideally anybody who has a diarrhea, it doesn't have to be the rice water profuse diarrhea before you start suspecting. Like we said, it's only 20% of those that have symptoms that have such severe cases. So really, we should have a strategy for testing all acute watery diarrhea cases. And that way we might be able to pick and early detect cholera and put in all the other intervention measures as necessary. Over. I see Dr. Kapaya has his hand up.
Yes, thank you very much, Prof. Just to add, so first and foremost, it's important to really strengthen surveillance for acute watery diarrhea so that we know exactly what is happening, like Prof has said. Secondly, it is important that all the countries, especially those that are high-risk countries, to conduct a risk assessment. In that risk assessment, for example, using the STAR, once you identify cholera as one of your priority diseases, you're going to have a risk calendar. So you will be able to tell when likely you are going to see cholera or an increase in diarrheal cases. So you will need to ensure that all acute diarrheal cases, especially towards the beginning of the peak period for the cholera, according to your cholera calendar, are being tested. And this is where we need to bring in issues of prepositioning our RDTs in all these risk areas so that we can quickly pick cholera once it presents. Thank you.
Yeah, thank you, Dr. Kapaya. So I see 3 hands raised. Maybe I'll take the first 2 and then we'll go to the next presentation and then we can, maybe in the interest of time. But before I take the hands that are raised, Dr. Patrick, I see your hand up.
No, in addition to all that you colleagues have said, there's one element that I wanted to bring in terms of our surveillance. And I think we have been, in most countries, been very good with our indicator-based surveillance in the health facilities, doing the syndromic surveillance for acute watery diarrhea or even the acute bloody diarrhea. But it's in addition to the fact that we have people who asymptomatic or who are carriers who are in circulation, I think the other aspect of our surveillance, the adjunct that we would have to our surveillance, which we have not been, which is not very strong in most countries, is the environmental surveillance aspect, which is an adjunct which helps us. One of it is the water quality testing or the microbiological surveillance that is done by the Ministry of Environment and Water, ensuring that the different water sources, that there has been no contamination that has happened, because these people who are harboring Vibrio and they are asymptomatic or mild, if any, like Prof said, one of these then gets into the water sources, you can quickly have an explosion once the water sources is contaminated. So having this happening in real time and linking it with the surveillance data on acute watery diarrhea, the syndromic surveillance from IDSR is very critical for countries. So that if you identify any of the water sources is contaminated, or even identification of Vibrio from the sewage water is an indication that already it's an early indication, an early warning that is contamination happening, and it's just a matter of time before you have an explosive outbreak, and you'll be able to take the preparedness actions that Kapaya has talked about. So we need to link the environmental surveillance, the water quality testing or water quality surveillance in real time with the epidemiological surveillance from the health facilities to ensure that we are able to detect early and respond.
Yeah, okay, thank you, Dr. Patrick. I see the hands raised, but I would want us to take the next presentation, because it's possible something from the next presentation would help in addressing some of the questions, and so that we manage our time properly. So I'll be inviting Fred Rativi, Laboratory Pillar Lead, to take his presentation. So over to you, Fred.
Thank you, Prof. Bola. Hello, everyone. Good morning, good afternoon from wherever you're joining. I hope in the presentation I'll be able to answer some of the questions, especially the one that wasn't complete, the negative RDT. Hopefully, by the end of the presentation, the participant will be able to get answers to their question. And in this session, we are going to be looking at the role of the laboratory in cholera response, what tools, diagnostic tools are in place for detecting or confirming cholera, and what testing strategies, some of which were already hinted on by the previous presenter, and what samples may be collected and how they are managed, and some aspects on water quality monitoring. So just to note, not all strains of Vibrio cholerae can cause epidemics. Only and only a few toxigenic Vibrio cholerae, O1 or O139, can, which is why it's important to characterize strains to confirm an outbreak, and in the course of an outbreak to routinely monitor the strains that are circulating. And why should we test for cholera? Before I delve into the aspects of why we test for cholera, I just would like to make a note that the clinical case management of dehydration takes precedence over testing. And so why should we test? As the previous presenter mentioned, in places where there's no outbreak or there are alerts, testing helps us to confirm and report the outbreaks. It also helps us to characterize circulating strains. As I already mentioned, not all Vibrio cholerae is capable of causing an epidemic. Only the toxigenic ones of O1 or O139 can. And also testing helps us to define the antibiotic susceptibility profiles. Testing helps us to monitor the spread of cholera if this were to happen in a new district, or if this were to happen in a new surveillance unit. And as already mentioned, testing helps us to declare an end to an epidemic. To test for cholera, there is a whole repertoire of diagnostic tools. And you do not have to use all of these tools on every individual sample and in all cases. So we have the rapid diagnostic tests, the RDTs, several commercial ones out there. However, WHO has only two in the catalog. That is the Crystal V and the SD BioLine, which are essentially used for screening for suspected cases of cholera and to rapidly detect probable outbreaks. And rapidly, I mean, you can be able to get your results within 30 minutes. And noting that rapid test kits are not 100% sensitive or specific, it's then not necessary to test all samples, especially where there's an ongoing outbreak. I'll delve into that in more detail in the subsequent slides. Now, RDTs also help us to triage samples that can be sent to the laboratory for confirmation of cholera by culture and sensitivity. Having mentioned about culture and sensitivity, now, excuse me, we can then do a presumptive identification of cholera using a combination of culture, oxidase test, or sera-agglutination. And culture is considered a gold standard, and it helps to identify Vibrio cholerae O1 or O139 serotypes within 24 to 48 hours. It also helps us to do antibacterial sensitivity testing that can inform case management. In addition to the two testing options, we have molecular approaches such as PCR that can generate results within 2 to 4 hours and helps in confirming outbreaks and identifying serotypes of cholera, and is used for toxigenicity testing. And it is important for countries to have mechanisms to confirm toxigenicity, especially where there's been no previous, there's been no ongoing outbreak. And if this capacity is lacking within the country, for the country to consider sending samples to regional or international reference laboratories. There are publications of in-house assays that work well, but they are not standard. That means you have to buy the different reagents separately. And there are also various protocols that labs need to develop and quality control issues. However, WHO can help countries or institutions in linking them up with suppliers who can provide these reagents and supplies. And also for PCR, there is limited field data in order to have a large-scale application of this. And countries may also use some conventional PCR reagents out there, depending on the testing platforms they may have. There's also sequencing, which can help in the identification of the type of the cholera, the lineage, and the virulence and resistance at the genetic level. However, I just would like to remind us that sequencing in itself does not change the course of the response. You do not need to stop and wait to sequence your samples first before you can have public health interventions to control the outbreak. Sequencing, of course, is useful to globally understand the transmission patterns, how the genes and of the circulating variants are evolving. However, we have limited in our region and globally. So countries may wish to consider preserving representative samples for later sequencing. There are some materials that you may refer to from the GTFCC, the Global Task Force for Cholera Control, that may help you perform different aspects of cholera testing. There are also versions in French. So because these slides will be shared, you may be able to get these materials in the presentation. Now, in order to adopt a testing strategy, a laboratory testing should consider an ongoing cholera situation at each surveillance unit level. Surveillance unit level was already defined by Felix, and the country needs to consider carefully what resources they have available. And as already earlier mentioned, expanded use of rapid diagnostic kits helps to support early detection of probable cholera cases and helps in incidence monitoring. And countries need to consider their capacities for confirming cholera through culture and sensitivity. This may not be in every district, but may be useful at the referral facility level. So what should a country do in situations where there is no confirmed cholera outbreak? The aim of testing here is really to support timely detection of an outbreak in a new district or geographical location in a country, and to characterize circulating strains of toxigenic Vibrio cholerae O1 or O139, and to define the antibiotic susceptibility profiles, which will help guide the response. What interventions may be put in place, such as water and sanitation measures that may be put in place, risk communication measures, and vaccination measures also that may be employed. And who should be tested? All suspected cases should be tested using RDT. And it's important to do culture and sera agglutination for all rapid RDT positive samples, and for the first instance to do confirmation of toxigenicity of the strain if necessary, if there's no epidemiological link with an ongoing outbreak. And also it is important to do antibiotic sensitivity testing for the first 5 confirmed cases per surveillance unit. And you may use rapid diagnostic test kits to screen and confirm by culture, and do anti-sera testing using specific O1 or O139 anti-sera, and then perform antibiogram. Toxigenicity may be confirmed using PCR. In surveillance units where there's a confirmed ongoing outbreak, the aim is really to monitor how the outbreak is spreading to new areas, and to monitor the circulating variants and antibiotic susceptibility patterns, and also to guide response. What are the hotspots in an ongoing response, the hotspots which are lately, according to the GTFCC guidance, called the priority areas for multisectoral interventions, and who should be tested. Testing in this case should be, sampling should be done in a systematic way. The country needs to choose a representative proportion of suspected cases per surveillance site using RDTs, and confirm in the lab by culture and sensitivity or PCR, and a subset of the RDT positive samples. And the GTFCC guideline recommends testing the first 3 suspected cases per health facility per day using RDTs, and testing 3 RDT positive samples per surveillance unit per week using culture and sensitivity. Out of these, to perform antibiotic sensitivity testing on the first 5 confirmed cases per new surveillance unit, and subsequently at least 3 on confirmed cases per surveillance unit per month. So I need to make this point quite clear that in order to have accurate and reliable results, the quality of the sample collection, how the sample is stored and transported to the testing facility, will determine whether the results are reliable. And for cholera testing, we use fecal samples of either stool or rectal swab from symptomatic individuals, usually in the first 4 days of the illness, when the bacteria usually are in high numbers, before ideally the start of antibiotics, and the sample should be collected in clean, chlorine-free containers. It is important to ensure that the person collecting sample or transporting sample or manipulating samples considers basic safety measures. For considerations for RDT testing, it's important to test the samples immediately with minimal delay. And for samples that need to be sent to the laboratory for culture and sensitivity, fresh samples should be transported in carrier medium in a triple packaging material. Please, I reemphasize, do not delay the rehydration of patients for the sake of taking a sample. Samples can be collected after the start of rehydration. Now, different stool samples can be collected in different containers, and there are different protocols. And whether in a stool container or in a carrier medium, you will find in this slide materials that you can refer to for further guidance. And the objective of sample packaging for transportation to the lab is so that it arrives rapidly in the laboratory in a good condition with minimal risk of contamination of human beings or the environment in the process of transportation. And here we encourage considering using triple packaging, and samples need to be accompanied to the laboratory using with a laboratory analysis request form. May I emphasize that samples need to be stored at the room temperature and not refrigerated, because refrigeration can significantly reduce the number of Vibrio cholerae in the specimen and may be missed in the culture and culture process. Now, once a sample has been collected, it is ideal to, it's important for countries to ensure the sample transportation and referral network is really efficient, and the materials may be handed over to the logistics manager or whoever is responsible for arranging transportation of samples using standard operating procedure for triple packaging for packing the sample and transporting. If triple packaging material is lacking, the country or the lab may consider a local solution of triple packaging as a plan B, but these materials should, as much as possible, conform to a triple packaging material, particularly if you're going to use the air transport to ship this sample. And just because you've invented a plan B, this should not become a norm. For international, it's important to check with the local couriers, DHL or TNT, how you may work out the logistics to be able to, and also to engage airport authorities and companies. There should be standard operating procedures for internal communication and information sharing so that the samples can be picked in a timely manner. Now, it's important to collect some basic data, metadata at the facility level, general information on the patient, the patient's address, clinical information, and at the sample testing level, also to report when the sample was collected, the date of the sample the laboratory. And it's important to report weekly the RDT and culture results. I just have put a note there that it is important during sample transportation to inform the laboratory focal point and all stakeholders who may be responsible for receiving the sample or picking the sample in a timely point. They are dispatched until the point of reception can be received without delay to maintain its integrity. So, about water quality monitoring. As already mentioned earlier by Patrick, Dr. Patrick, in his intervention about heightening surveillance for cholera, it's important to do water quality monitoring to ensure access to safe water sources that are free of fecal contamination to prevent outbreak and limit spread. There are two ways of water quality monitoring. The chemical one, where free residual chlorine levels are normally detected, will be discussed in further detail by colleagues in WASH in subsequent webinar series that Professor Bola talked about that will be coming your way in the coming weeks. But the biological aspect of water quality monitoring involves testing for the presence of indicator bacteria, the presence of E. coli, and not Vibrio cholerae. I would like to emphasize that it's not Vibrio cholerae presence in water water sources that should be used as an indicator of fecal contamination. So drinking water sources should be tested routinely, and for places that have endemic or ongoing outbreak, it's not recommended to look for Vibrio cholerae in drinking water sources. And the exception here is this may be done as part of safety investigation, or if the epidemiology points to a single source contamination, and if the removal of that source would otherwise lead to control. And there's material there to show for you to further read about water quality monitoring procedures. What about environmental surveillance? Now, looking for Vibrio cholerae in the environment, such as rivers, lakes, is really not recommended. In non-endemic contexts, this may show increased risk. However, it's important to distinguish, as I said earlier, between toxigenic Vibrio cholerae O1 or O13 and other bacteria and non-Vibrio cholerae. And detection of Vibrio cholerae in the environment does not necessarily translate into an increased risk, nor non-detection does not translate into zero risk of the outbreak. Why then, what should we then do when there's a positive toxigenic Vibrio cholerae O1 detected in the environment? It's important to communicate the risk and engage the community. As we know, outbreaks start in the communities and end in the communities. It's important then also to recommend procedures for food safety, hygiene promotion, cooking our food well, peeling and boiling. Again, it is important to focus resources for testing of clinical suspect cases and then drinking water. Finally, as already mentioned by Professor Bola, in order to prepare well for cholera outbreaks, or when there are multiple outbreaks, it's important to check what laboratory confirmation, what stocks of laboratory confirmation reagents or RDTs are in place. It is important to check also the availability of your triple packaging and managing this responsibly. It may be important to preposition and ensure the available rapid diagnostic kits in places where there are no ongoing outbreaks. I would like to conclude by saying testing does not prevent clinical case management of dehydration, but testing helps us to quickly confirm suspected outbreaks and helps us to monitor ongoing outbreaks and susceptibility patterns in the cases where there is an ongoing outbreak. I would like to thank you for your attention, and we'll be happy to take any questions and hope we have been able to answer some of the questions that were raised earlier. Thank you, and back to you, Professor Bola.
Okay, thank you, Fred, for the presentation and for the explanation provided. I believe with this, some questions have been answered. And I also noticed that there have been some questions asked in the Q&A. A lot of them have been responded to by the lab team. Thanks, lab team from HQ. I see you very active on the Q&A and just responding to a lot of the questions. So thank you very much. Okay, so I'm looking at the Q&A and apologies. I need to change my view. Okay, I see two hands raised up. So I'm going to call on the first person to ask. And please, as much as possible, in view of a time, would appreciate if you could type your questions in the Q&A, and then we could also respond to as many questions as possible. So Hawa Bawa, can you ask your question, please? Hawa? Hawa, can you unmute and ask your question? Hawa, can you unmute? We can't hear you. Okay, Usman, while they're trying to sort out Hawa being able to speak, Usman, are you able to unmute and speak?
Merci. Bonjour. Bonjour
Yeah,
à tous.
bonjour, Usman.
Merci pour la parole. Mon souci, c'est au niveau de l'approche communautaire. Vu qu'il y a certains pays, il y a certaines locales qui sont très éloignés et avec l'inondation, avec certaines mauvaises habitudes, les gens continuent à boire de l'eau stagnante. On a eu une fois des alertes et il y avait des signes typiques, symptomatiques, tout ça, mais on a vu qu'on n'a pas pu avoir l'accès à analyser l'eau, la source d'eau, est-ce qu'elle est contaminante, on a prélevé, mais comme vous le voyez, l'approche communautaire fait défaut. Je voudrais savoir, est-ce que ces tests-là, réellement, c'est des tests qui sont disponibles, accessibles pour être utilisés en milieu rural, pour permettre de diagnostiquer efficacement, de manière précoce, les 001. Merci.
Okay, thank you, Usman. I will answer in English, but I'm sure you can get interpretation in French. So we know there are challenges in our rural areas with even access to any form of water. And many times people just take whatever water is available. So when we talk about community engagement, there are different ways by which we look at it. One of it is for the community to agree to make their source of water safe. And there are different ways by which they can agree to do this. For example, they could prohibit open defecation, because for that water to get contaminated, it means feces has a way of getting to that place. So the community can engage and agree to a means of ensuring that that source of water they have is not contaminated. The other way is to treat the water, and there are different ways by which this can be done. And then the third way is, even if that is the only source of water they have, how do they make it safe in their households? And there are different ways. It could be by filtering, it could be by boiling, and it could be by using chemicals. Now, water testing in the community, as important as it is, it's not just enough to test. If you test and the water is unsafe, then it means that there must be a way of providing safe water. So it's not enough to test. Testing is to tell you the water is contaminated, but then once you say the water is contaminated, what other source of water is going to be provided for the people? So this has to be thought about comprehensively, not just the testing, but you've tested, okay, the water is unsafe, then what are the next steps? So, and this is why we talk about community engagement, because it is also discussing with the people and agreeing to the best way out. Over and thanks. Is that still another hand or the old hand, Usman?
No other hands.
Okay, so let's just quickly go through the Q&A and let me see if there are any questions that haven't been answered. Okay, so there's a question on, thank you very much for the presentation. Can we have it in our mails? Yes, you will get all the presentations as a registered participant for this session. Then there's a question, and I think this is for you, Fred. What is the testing criteria for ongoing outbreak in order to determine if you're still in the outbreak or not?
Okay, if I may.
Okay, before you answer, let me just answer a few. So someone is saying, can we share what topics will be handled during the third session on the 14th of September? Okay, so here we are doing surveillance and laboratory. Next week, we'll be dealing with case management, infection prevention and control, water sanitation and hygiene. And then on 14th September, we'll be discussing community engagement and risk communication. We'll be looking at oral cholera vaccination, reactive vaccination, and then we'll also be looking at operations, supply, and logistics. You know, many times people order cholera kits. You'll be told the different models that are available. What's the difference between a community kit, a lab kit, an investigation kit, a central model kit, a peripheral model kit? So we'll be talking about all of those on the 14th of September. And then there's a question here in French. Est-ce que la surveillance environnementale prend en compte la gestion sécurisée des, what's this? Des déchets biomédicaux? Okay. Taking into account what? Déchets? No, there's a déchets biomedical. Yeah, I'm not sure myself. Okay. So is environmental surveillance, does it take into account now sécuriser des déchets biomédicaux? Now my French is, okay, we'll try and sort that out and get back to you. Okay, so over to you.
Prof.
Yeah.
Oui, en définitive, le collègue Fred a indiqué ce que l'on fait pendant la surveillance environnementale. Ce qu'il devrait aussi ajouter, c'était que, au-delà du test de la qualité de l'eau, il y a le besoin d'utiliser aussi ce que l'on appelle le formulaire d'inspection sanitaire, qui permet en soi de vérifier l'intégrité de l'infrastructure en place et donc de s'assurer que l'eau n'est pas contaminée à quelque niveau que ce soit. Et c'est ainsi que l'on vérifie que l'assainissement est bien géré, et cela inclut certainement la gestion des déchets biomédicaux. Merci.
Okay, thanks, Guy. Good to see you on board, and thanks for coming on board. Okay, so over to you, Fred.
Thank you, Prof. Bola, and thank you for that question regarding the declaration of an end. I think Felix in the previous presentation talked about how an ongoing outbreak could be declared over. And he did mention two scenarios. where a suspected, probable, or confirmed cholera outbreak can be considered over when for a minimum of 4 consecutive weeks, all suspected cases had a negative culture or PCR. He also said, if all suspected cholera cases with a positive RT test that triggered the probable outbreak had a negative laboratory test by culture or PCR, he downgraded probable cholera outbreak. To a suspected cholera outbreak. I hope that answers the question. I think Felix. Thank you. Back to you.
Okay, thank you. I'm just trying to, I'm seeing some questions have been answered. We've talked about the testing criteria. Was that the one you answered just now, Fred? Testing criteria for ongoing outbreak in order to determine if you are still in the outbreak. But maybe I can say something around that. The reason why you need to test is because as much as we focus on cholera, we are not unmindful of the fact that there are other causes of diarrhea. And so, yes, during surveillance, it's not, I mean, once you have it confirmed, you don't need to test every case. But when you want to declare over particularly, just like when you want to declare that you have an outbreak, you must confirm that you no longer have cholera, even though there might be other organisms, whether they're bacteria or viruses or parasites, that are causing the diarrhea. And that's why it's important that before declaration, you still do the testing.
If I may, Prof. Bola.
Yeah, please go on.
Yeah, I think I misunderstood the question, and specifically answering the testing criteria when there's an ongoing outbreak. I did mention, according to the GTFCC guidance, we have to take the first 3 samples per surveillance site per day in order to monitor using rapid diagnostics test screening, and then send 3 of these RDT positive samples to the laboratory for confirmation. So I don't know, I hope that precisely answers.
Yeah, no, that's fine. That's fine. Thank you.
I see the hand of Nadia, who may wish to add.
Okay, before Nadia comes up, somebody asked a question and I think I want to answer that. The question is, who is responsible for declaring an outbreak in any country or in any district? It's the government of the country that does the declaration of an outbreak. And usually what happens is that when the country declares there is an outbreak, then they send a notification to international health regulations to say, look, we have an outbreak here. So I just needed to answer that. So Nadia, you have the floor.
Yes, thank you very much, Adebola and Fred. I just wanted to add that indeed, in the case where we are winding down towards the end of an outbreak, we do recommend that testing the strategy is slightly switched back to, confirming as much as possible all RDT positives to find those last few cases. But basically, from the presentation from Dr. Sani is, indeed, if there are no further confirmations over a period of time, which is slightly different in different circumstances, whether you are in confirmed, probable, or suspected outbreak. But basically, if all tests come out negative for 4 weeks, that is when the outbreak is declared over. So I just wanted to make that point on the switch back to maybe more precise testing towards an end to look for those final cases. Thank you very much.
Yeah, thank you, Nadia. So I can see there are lots of questions related to water testing, water quality, and I'll just encourage you to attend the WASH session, which is next week, same time. And then we'll have the experts on board to answer, and I'm sure the presentation would likely address some of this also. So there's another question, and I think maybe it's Fred or Nadia talking about what are the RDTs for cholera in the market.
So if I may.
Yeah, go ahead.
So as I mentioned earlier in the presentation, there are a whole host of rapid diagnostic kits out there in the market. But for as far as WHO is concerned, there are 2 that have recommended, the Crystal V and the SD BioLine. These are recommended because they have had a wide field studies conducted on them, and so those are the 2 that WHO recommends at the moment. Thank you.
Okay, thank you. So there's a question: if an area has been endemic and hasn't recorded a case in 4 years after OCV, is there a possibility that the Vibrio cholerae could still be in the environment? If so, how can the Vibrio cholerae survive in an environment?
Okay, in general, cholera does survive in the environment. With regard to, I don't know the precision of the question in relation to OCV, but yes, some studies have shown that. I hope I get to the intention of the question, but there are some studies that have shown that OCV campaigns have generated some viable Vibrio cholerae in the environment in, I think, within 6 months, if I can recollect well. But then in the subsequent testing, confirmation, and toxigenicity analysis, then they should not be able to, there should not be a problem. Thank you.
Okay,
Antoine,
thanks,
would you
Fred.
like to add?
Yes, I would like to add. Thanks. And in addition to what Fred mentioned, we know that Vibrio cholerae loves an alkaline environment. So when you have alkaline water bodies, and you could actually have Vibrio cholerae surviving in those water bodies. And that's really one of the reasons why, whether there's an outbreak or not, there is emphasis on ensuring that the water you're taking in is safe. In a few aquatic environments also, it's been found that some crustacea could kind of harbor the Vibrio cholerae. And so in such places, you also encourage the proper cooking of crustaceans that are being eaten. So those are just some few and additional points. So there's another question, and I'll just provide an answer. Somebody says, what is the testing criteria for an ongoing outbreak in order to determine if you are still in the outbreak or not? I think this was clearly presented, but we'll be sharing the slides with you, so you may go over it at your own pace to understand. And there's also the link to the new surveillance guidelines by GTFCC, which also provides a clear description of the testing criteria pre-outbreak, during outbreak, and also in declaring an outbreak over. Antoine, I see your hand up. You have the floor.
Thank you. I just would like to ask to add to what you said and Dr. Fred regarding the introduction of OCV and the presence of Vibrio cholera in the environment. Just to make it a bit clear, introduction of OCV will not affect the presence of Vibrio cholera in the environment. Vibrio cholera is a bacterium that lives on this planet, has its own environment and can grow and multiply by itself. However, introduction of OCV and proper implementation of WASH will limit the presence of Vibrio cholera in humans and in patients. So the idea is, if we introduce OCV, that does not mean that Vibrio cholera will not exist in the environment anymore. We just need to keep good control on the water and the level of sanitization that we are introducing to the water and the access to safe water, and the introduction of OCV in case there is an outbreak in a certain area. Thank you.
Okay, thanks. There's also another question on le different test rapide pour confirmer le cas de cholera, asking about the different RDTs for confirming cholera. So I think it's important to mention that we do not use RDTs to confirm cholera. We use them to screen, and then confirmation is done by culture or by PCR, the details of which Fred clearly explained in his presentation.
Okay.
Yeah.
I just wanted to add, for the benefit of those who have joined this the webinar, that there are more training materials that we, together with the colleagues at HQ and GTFCC are working on, that will be available for capacity building at the lower level facility, at the health facility level in the community, and at the National Reference Laboratory. So colleagues, be glued, engage, and these will come your way in the coming month or so. Thank you.
Okay, thank you. And then the last question I'm seeing in the Q&A, it says, does Carrie-Blair transport media need to be kept at 2 to 8 degrees during transportation to the National Laboratory for Culture? Fred, over to you.
Thank you. As I said earlier, importantly, the Carrie-Blair medium doesn't need to be frozen. It may be carried, the triple package does not need to have ice packs. Keeping it at room temperature, keeping the sample at room temperature in Carrie-Blair medium can maintain the bacteria viable for up to 7 days. I note there has been a whole host of questions about that. I hope that responds to that question well. Thank you. Antoine?
Yes, Fred, thank you for your answer. And I just want to add, room temperature we are discussing, we mean temperature should be at 22 to 25 degrees. There is no need to use cool packs or ice packs to lower down the temperature unless you are certain that temperature is gonna increase beyond 25 degrees, and the cool packs should not be placed right next to the sample. Okay, so in the triple packaging, it should be between layer number 2 and layer number 3, but not between layer number 1 and layer number 2. If you actually lower down the temperature on Carib layer to 2 to 8 degrees, Vibrio cholera will die. Your culture result will be misleading. It's very important to keep it at room temperature so it lasts the 7 days as GTFCC recommends.
Okay, thank you, Antoine. And now I'm just, is Patrick still with us? Yeah, Patrick, a few closing words, closing remarks before we end the meeting.
Thank you very much, Prof. Bola, and thanks to all the panelists for dealing, I think, comprehensively with the concerns and questions that colleagues had. But more importantly, I would like to thank everybody who made time to attend this webinar, the first in the series. And I would like to encourage that we continue to attend so that we have the complete range of information that the colleagues are prepared to share with you. As we had noted earlier, this is a disease which is stubbornly refusing to go because of the predisposing factors that we have in our region. And we have to get better in terms of managing. Really, the message, I think, the whole day has been that every cholera death can be prevented. And we have to do all that we can to ensure that we prevent the deaths. So far, we have not been very good at that. As I mentioned, that we have had over 4,000 deaths from January last year up to now. And we want to be able to eliminate those. And secondly, we want to limit the spread. And every year we have at least 22 countries within our region that report cholera outbreak. This year there have been 15. But even with the 15, we have had cholera cases that have exceeded the number that was reported last year, which was over 80,000, and the number that was reported in 2021, which was over 130,000. So we have already exceeded that. Therefore, we need to do all that it takes to limit the spread. And the initial sessions today really set up the ground for us in terms of the strategies that we need to use to effectively respond to cholera outbreaks, the surveillance aspect, which is very, very important, what we need to do, how do we start, how do we say we have an outbreak, how do we declare the end of the outbreak, but most importantly, also with the lab in terms of how do we identify what are we dealing with, and laboratory confirmation is very critical. So I am quite optimistic that we have gotten knowledge that will be relevant for us in our everyday response in countries. And I'm encouraging that over the remaining sessions, we will continue to actively participate like we have done today. The information will be shared and the colleagues remain available to continue to provide remote technical support. We have a robust cholera response incident management support team here at the region office, as well as at the global headquarters, that works very closely with the GTFCC to ensure that you get all the support that you need. You should not struggle if you have questions or other challenges that can be clarified. We are available to be able to support, and the colleagues that have been on this panel and others who have not been here will continue to provide answers and avail additional information to ensure that we are effectively equipped to deal with cholera in our region. So thank you, merci beaucoup, shukran jaziran. We hope to meet again.
Yeah, thank you, Dr. Patrick. I'm kind of seeing 2 hands that just, or 3 hands that came up. I'm hoping we are actually rounding up. Are there burning questions? Serge. Serge Colombo. Can you unmute?
Oui, allô, bonjour à tous. C'est juste... Voilà. Je voulais juste savoir quelle est la conduite à tenir. Vous avez dit que le test rapide était utilisé pour le dépistage, c'est pas pour la confirmation. Maintenant, je voudrais savoir devant un test rapide positif.
Okay, so if you have a rapid test that is positive, you need to confirm with culture or with PCR before you can declare that there is an outbreak. Is that clear? Serge, is that clear? Okay, somehow I'm not here. Okay, thank you. Okay, so once again, to all our participants, thank you very much for coming and joining us this morning. It's been a very rich time. Like we said at the beginning, we will share all the slides, the presentations. We'll also share the recordings. And the recordings, we can share the recordings to you in French, in Portuguese, and in English, so that you can really understand the language that you prefer. And let's remember that next week at the same time, we have another training. Actually, till the end of November, there will be different trainings on cholera. And I can tell you that the presentation in each week is very different. Next week, we'll be looking at managing cases. How do we effectively manage a case of cholera and even manage the complications? When we talk about IPC in cholera, what do we mean? What exactly needs to be done? And then all the questions that have been asked regarding WASH, we'll be having also the WASH presentation next week. So please, let's register on time and let's join the session. We're trying to limit it to only 2 hours, and it promises to be an enriching session. And like we hope, like the IM said, as we get to know more about how to respond to this, we will be able to bring our numbers down in our countries. And of course, we'll be able to achieve the less than 1% case fatality rate for cholera. Thank you, everyone, and enjoy the rest of your day. Merci à tous. Bonne journée.